I bring greetings to you from India. And of course, today I'm going to be talking on use of energy when and where in hysteroscopic surgery. And that's what the discussion started off about, using cold surgery versus electrosurgery. And so there is a big debate on whether we should use electrosurgery. We all know that endometrium, which is so very important, especially in reproductive age group, and endometrium is a lining which can fall every month and regrows within the next 28 days for the ready for the implantation. Well, why does it get affected by pathology, especially like intrauterine adhesion? The molecular pathophysiology is still not understood, but we all know that this particular cavity is very important for all of us for implantation, and those who are dealing with ART or IVF always want a very beautiful, good-looking endometrium like this. So if this gets disturbed, even the best of embryos is not going to get implanted. But why does this happen, that there are pathologies inside the uterine cavity by our own surgeries? So today, we do hysteroscopy commonly for the indications in reproductive age group, basically for intrauterine adhesions, patients with recurrent pregnancy loss, pre-ART IVF, diagnosis of Mullerian anomalies, and in patients who have otherwise abnormal uterine bleeding where there are intrauterine pathologies like polyps, submucous fibroid, hyperplasia, postmenopausal bleeding. These are the most of the common indications which we advise our patients to go through hysteroscopy. Well, when we start talking about energy in hysteroscopy, about 2 decades back, for every surgery in hysteroscopy, I remember we were using the resectoscope, and that time we had the 26 French only available. But today, with increase in experience and better equipments, we are able to use the smaller diameter sheet, thereby this 2 millimeter scissors and other graspers very efficiently. And today, if at all we have to go for electrosurgery, I'm sure most of you will agree that one may not talk about monopolar much. We all do more of bipolar electrosurgery. Well, electrosurgery, of course, as I said, if you're using monopolar, it has to be in a non-conductive media where we cannot use saline or ringolactate because they contain electrolytes and they can conduct the electricity. Well, we use glycine, whereas bipolar has an advantage where one can use normal saline, which is not only physiological, but even the basic principle of current. We know that both bipolar is much more safer because the return is very near to it. It doesn't go through the patient and there is no need of patient plate. So both the energy itself is much more safer than monopolar. So today I don't think I will talk about monopolar in electrosurgery, in hysteroscopic surgery at all. Well, about the media safety, we all definitely know that saline and ringolactate are the most safe solution, and they can be used both for diagnostic and operative. And glycine, with all its complication of low osmolality, hyperammonemia, temporary blindness, encephalopathy, electrolyte imbalance, I think it should not be used in hysteroscopic surgery at all. Well, prior to the advent of hysteroscopic surgery, dilatation and curettage was the only culprit which would cause intrauterine adhesion. But today we are using more of hysteroscopic surgery, and we can see this particular article in the JMIG by the AAGL. Use of hysteroscopy has increased the incidence of intrauterine adhesions, myoma, multiple myoma, septum, where we all were using electrosurgery, can lead to more of adhesion. So that means definitely we are causing more harm than what we want to endometrium, especially in patients who are for fertility treatment. So we have to wake up and see what can be done to minimize this injury, this damage to the endometrium. And luckily for us, with the innovations in hysteroscopic surgery, we have the smaller diameter telescope with the smaller diameter sheet, which we can perform ambulatory hysteroscopy, which Dr. Professor Monti was insisting upon. 4 millimeter sheet, we can pass on the 2 millimeter scissors and do many of the biopsies, many of the small polyps. Well, resectoscopic surgery, in our practice, we use it only for 20% of cases. where we are really bothered about electrosurgery, basically restricting it for myomas and very large vascular septum. Well, we are lucky that we have the smaller diameter resectoscope today. We can use the 15 and 16 French, which is hardly 5 or 6 millimeter, and many of them can be used even in the ambulatory settings. So that's where we stand today as far as hysteroscopic surgery. Well, if I look into particular surgery, step by step, one surgery, where you should use only cold and where you may have to use the electrosurgery, it's agreed totally that in patients who have already damaged endometrium in intrauterine adhesions, we should avoid using any form of electrosurgery. Today, we have learned the way of using only scissors in one of the most severest form of Asherman's. Well, you can definitely see that Asherman is one condition. If you pick up early, you are lucky. That you have to diagnose that after a particular procedure, if a patient comes with oligomenorrhea or amenorrhea, put in the ambulatory hysteroscope sooner than later. Here you can see on the left side where the anatomy of the uterine cavity is still maintained because you have picked it up early. You can see the tubal ostia. The adhesions have just started developing. You can identify the ostia and you can cut that adhesions with a simple scissor. Absolutely no need of any anesthesia here, can be done in ambulatory, no energy is required. Whereas on the right side, you see the video where a woman has come after 3 years of her temporary procedure, where you can see even the internal ostia is obliterated. Means there is zero cavity. And here, if you remember, if you have to dilate it and use the resectoscope, you will wonder whether you're in a false passage. But use that scissors very judiciously. All the mucosal fold will lead you into the internal os, and you just open it up and use that scissors to occasionally dilate and lyse those adhesions. Starting with the central adhesions, you know that hysteroscopic or uterine cavity is an inverted triangle with the tip at the internal os, and you can very beautifully cut all the different adhesions with the scissors itself. Here you definitely do not want any sort of energy because you can see that the endometrium is already damaged, and you would be happy whatever endometrium grows, and we do not know how much will be the thermal damage to the endometrium if at all we have to use any sort of electrosurgery. And you can see that as we go on cutting, we can then go to the lateral side and do a proper cavity which is triangular shape. You may be lucky to see the tubal ostia many a time. As you can see in this case, there is good level of endometrium. Well, we have created a cavity from absolutely zero position. So this patient will do better, but this severe adhesions patient will require a relook hysteroscopy after the first procedure. Now, there are very few studies to tell us whether thermal damage by electrosurgery can harm the endometrium, but this study on intrauterine adhesion by the Chinese group of Yang and Wang, you can see that they have compared a large meta-analysis where cold surgery versus electrosurgery, and you can see beautifully that they have found out that the menstrual blood flow is significantly better whenever the cold surgery or the scissors was used. So it favors that have a normal regeneration of endometrium with increase in menstrual flow. Scissors is much better without use of electrosurgery. Well, though this study didn't find a very significant improvement in the pregnancy rate between the electrosurgery and the cold surgery arm, but definitely few of the studies do have a small favor towards the cold surgery rather than electrosurgery as far as pregnancy rates are concerned. But maybe further studies will tell us that we should continue to use cold surgery rather than electrosurgery, at least in Asherman's. Well, septum, again, a very, very common problem in patients with recurrent pregnancy loss. Well, for us today, any septum, if you find in a patient within the reproductive age group, should be tackled, and we would recommend that you should start off with the 2 millimeter scissors, remaining in the midline, following all those principles of proper hysteroscopic surgery, identifying the tubal ostia, remaining in the midline. You can see 80% of the septum you can cut, as you go on to the base, you may get a little more muscular, vascular septum, where occasionally you will need to use the energy. Again, septum is the slowest amongst all the hysteroscopic surgery. It takes 3 months. So again, it emphasizes that if you cause less thermal damage, healing will be much better. And we all believe incision of septum is still the answer rather than resection of the septum. You can see that the scissors is doing a wonderful job. Though occasionally you may get little bit bleeders, do not bother about them. Continue your incision up to the end point where you will remain just below the tubal ostia. You can see as we still go ahead, we can do a good job without bothering about the bleeding or the damage to the endometrium. And you can very beautifully see that this beautiful fibrotic septum is being cut with efficient scissors, and one must learn the technique of doing septal incision with scissors rather than using an energy with a Collins knife or an electrode. Whenever possible, always start off with the scissors, go ahead with the scissors, but you can always change over to any of these electrodes or Collins knife if at all you get more vascular and muscular septum. Well, you can see if at all you want to use the electrode or energy, you can go ahead and use these thin bipolar needles or the twizzle electrodes. Well, you know that they are efficiently and they can go through the 2 millimeter channel of the operative sheath of a 4 millimeter or a 5 millimeter sheath, and you can complete the septum if at all there is bleeding. So this is the only place when bleeding occurs we would do, or the septum is very large or very muscular at the base, we may go ahead and do with an electrode. Well, sometimes we do get complete septum, as in this case where you can see the uterus fundus is absolutely normal. Well, this was a patient who sometimes we get patients right from the vagina, they have septum. So here we are seeing the technique of using the Collins knife for the vaginal septum. You can of course cut it with cold scissors here, but just for reducing the bleeding, this still is a good method. You can do the vaginoscopy way of cutting the septum inside the vagina, and you can see 2 ostia there, the tubal or the cervical os is divided, and you can enter from one side of the cavity. Here you cannot do with a cold knife or a scissors because the septum is very difficult to cut. Well, just starting above the internal os, you perforate. Here we use the energy because this is the only place otherwise in a septum, either in a Robert's uterus or a complete uterovaginal septum, you can just perforate just above the internal os where the septum is thin with your Collins knife, and then you can see the other side of the cavity is very well seen. That means you are now converted a full septum, complete septum into a partial septum, and then you can do the same way as you saw with the help of scissors with the ostia always under vision. Well, you can see that this septum is a very broad one. You can have bleeding in this, so better to do with the energy in these patients. Well, this will take sufficient time for healing. You might have to use some of the intrauterine adhesion barriers. Well, this particular study by Attilio Sardo et al. About T-shaped uterus classically diagnosed by 3D ultrasound. Again, we would recommend that if at all in a T-shaped uterus, we have learned the way of using cold scissors rather than a Collins knife or energy. You just fixed one of the blade into the lateral part of the cavity and then move the moving blade, and you can convert the T-shape into a normal uterine cavity by bilateral metroplasty. And this study showed a very good improvement in pregnancy rate, not only spontaneous, also in assisted reproductive technology. Here again, for lateral metroplasty in T-shaped uterus, after proper classification and diagnosis, we prefer to use the cold scissors rather than the energy. Well, polyps, again, a very common condition, more so common in patients who are in the perimenopausal or the menopausal age group rather than the reproductive age group. But here again, one definitely would want to use the scissors whenever possible. But if you're lucky enough, as you can see in this postmenopausal patient of 65 years, where the pedicle is very thin. So in these patients who have a very nice pedicle, you can use the scissors. There may be a bleeder, but doesn't bleed much at all, and you can cut the polyp with the scissors, and this sort of a long polyps will very easily come out of the internal os, even if it is not dilated, and you can use a grasper to grasp it properly and then squeeze it out and bring it out of the canal. Well, if at all the polyp is big, you might use the electrode to lyse them and then bring it out of the, because polyps always one has to have for biopsy. So this is the way of dealing polyps, where we use it. You can see how beautifully you can grasp it and get it out of the canal and the external os. Well, the polyps may not be always be as small or as tiny. The base may be sometimes very broad. There may be multiple polyps, where you can see on the right side a giant polyp in a postmenopausal woman of almost 5.5 centimeters at 75 years. Here we are seeing a resectoscope, but with the availability of this 5 millimeter and 6 millimeter Gubini resectoscope, which you're seeing on the other side, you can enter without dilatation again by the vaginoscopy in the ambulatory. And these polyps, which have a wide base, are very difficult to handle by the scissors. And if there are multiple polyps, again, we tend to use energy, of course, in patients who are not in the reproductive age group, because damage to the adjacent endometrium has to be minimized. Well, you can see these polyps can be cut with the smaller diameter resectoscope also, though they are smaller, but for polyps, these are excellent in the ambulatory settings too. Well, myoma, submucous myoma is one such condition where your scissors is not going to be very effective unless it's a type O and a small pedicle, where you can just cut the pedicle and leave it. But most of the fibroid, especially this one with LASMAR 7 or 8, you can see where it is type 2, majority of the fibroid is into the myoma, and you have a very small projection. Especially the lateral wall fibroids are very difficult to treat by any other method. So you need to have this resectoscope. So whenever we have such large myoma, we always prefer to use the 9 millimeter resectoscope with the large loop, because the resection becomes quicker, where time is a factor and you want to avoid fluid absorption into the system. Where I wouldn't discuss the end point, we are just trying to discuss where energy has to be used. But today, for type 1 and other fibroids, we have found the way of whole loop myomectomy described by Mazzoni et al., where you might enter into the pseudocapsule, subcapsular, by dissecting with a grasper and dislodging the myoma from the intramural bed and just leaving it into the cavity, and for it to fall after a couple of weeks. So that is, of course, it is a matter of time for us to learn all those cold loop myomectomy, but you cannot use it in every case. Like this LASMAR, again, we prefer to use the resectoscope or the bipolar energy. And if plasma energy, which has just come into the market, I've used it in a couple of cases and found them to be quite effective, or as effective as the conventional bipolar resectoscope. Well, you can see the trick of doing the myoma resection. The problem will be the debris which keeps coming in your way. Bubbles are always a problem in bipolar energy, as you can see, but you don't have to be bothered about these bubbles. Don't get disturbed by the repeated appearance in your screen. You can just push them off to one corner and continue with your surgery. Well, intrauterine retrieval systems have come in a big way, and they have been advocating that it doesn't use energy, no current application, it's mechanical, there is fluid overload is much less, the view is always clear because the debris is being constantly sucked, and the diameter is also much smaller, can be used in the office setting, whereas the conventional resectoscope always needed the larger resectoscope. Well, this RESMO study did prove that for polyps, maybe the intrauterine retrieval systems or the morcellators are much better than the conventional resectoscope. Well, even in patients who are for reproductive age group, those who are using it do advocate that this causes less thermal damage, and definitely a big place in patients who have polyp, especially in the reproductive age group. We can think of using no electric energy but a mechanical force, but at the same time you get continuous evacuation of the cavity, so it becomes much faster and thereby reducing the fluid overload. Well, whereas the intrauterine morcellator retrieval system are used. Well, I would recommend in patients where you're thinking of hysteroscopic removal of cesarean scar pregnancy, which is again on the rise. Well, again, for products of conception which remains in the uterine cavity, especially the patient is agreeing for fertility treatment later, this becomes a real boon where you don't use energy, where you can see on the left side the Bugatti shaver shaving off the cesarean scar products of conception segmented in the lower segment under laparoscopic guidance. If at all you have to use current, you're always worried whether you're going to perforate the cavity and enter the bladder. Whereas you can see on the other side, so much products of conception seen in the uterine cavity. If you have to cure it out, you are going to cause more intrauterine adhesion. So again, less thermal damage by using these intrauterine morcellators. So a very big place for intrauterine morcellators in cesarean scar pregnancy and retained products of conception, where we use it a lot in the ambulatory settings, also in patients who have incomplete evacuation of uterus or incomplete emptying of the uterus following an abortion. Well, plasma RF energy, Professor Monti is a very expert. We would like to see more of his video. We have heard that it causes a lesser thermal damage because of its less heat. There is less lateral spread, but we do in India, it has just been introduced in the last couple of months. We still have less experience in use of this. I've used it in a couple of my workshops here, and they have worked well. Here you can see a twizzle electrode cutting a polyp in a patient with a large base leading to menorrhagia, and it did work well. But I wouldn't know whether the lateral spread and the thermal damage, is it less than the conventional bipolar? Maybe further studies and further our expertise will tell us that, of course, yes, these are better than the conventional bipolar scope, and we may start using it more. Well, intrauterine adhesions, which I just discussed, and the energy use in general, intrauterine adhesions was found to be lower whenever cold Caesars were used rather than with electrosurgery. And Professor Mazzoni et al. Has reported that with the use of cold loop hysteroscopic myomectomy, intrauterine adhesions, which is otherwise 35%, was much less, and the injury to the endometrium caused by the energy-based local hypoxia, reduced neovascularization, and increase in the inflammatory cytokines and fibroblast growth may damage the endometrium. And we can definitely say that the bubble formation is much less whenever you're using cold surgery, and the damage to the endometrium is less, so it could be beneficial for implantation. And if at all you have a complication like perforation with a resectoscope, your damage to not only the endometrium or the uterus, even the adjoining structures is much more. Here you can see a perforation which occurred with a grasper, and you are not worried because no energy damage to the intestine which is surrounding the uterus, and you can see just a laparoscope to find out there's hardly small hole, and you can just leave it. The adjacent intestines are much more safer. So friends, thank you for a patient hearing. So the take-home message will be changed to miniature hysteroscopy and use less of resectoscopy or energy, more of hysteroscopic surgery with cold Caesars, and don't neglect the basics of anatomy, fluid dynamics, and electrosurgical principles whenever you have to use electrosurgery. Thank you once again for a patient hearing.